You know, when we talk about the maternal health crisis in the US, our minds usually jump straight to the clinical side of things. But what if the root of the problem isn't just in the delivery room? What if it's actually in the delivery system? Today we're diving deep into the economics of maternal care, looking at a system that's under some serious strain and the really smart ideas people are coming up with to fix it.
So here's the game plan. We'll kick things off by looking at where the system is breaking down. Then, we'll unpack the two big challenges: how we pay for care and the workforce shortage. From there, we'll get into the exciting stuff: a totally new vision for care, how we can redefine what value even means in health, and finally, how we can start measuring the things that are actually going to make a difference.
All right, let's get right into it. To really understand where we need to go, we've got to get our heads around the scale of the challenge we're facing right now.
Just look at this number. It's pretty staggering. By 2035, we're projected to have enough OBGYNs to meet only 82% of the country's demand. And this isn't some far-off, maybe it'll happen problem. We're literally walking towards a demographic cliff right now, and it's pointing to a massive crisis in access to care.
Now, it's so important to get this. There's no single villain here. The problem is this really complex, tangled web of a strange system, payment models that are frankly ancient, and that workforce shortage we just mentioned. Today, we're going to zero in on one really critical thread in that web: how we pay for care. It's a system that's put unbelievable pressure on providers, and honestly has been holding back progress for decades.
So let's pull on that thread a little harder. The real tension, the agitation in the system, it really comes from these two problems that are totally connected: the economics of how we pay for care and the shrinking pool of people who are there to provide it.
This chart just lays the problem out so clearly. Look at that red line. I mean, the shortage is going to hit everyone, but the impact on rural America is projected to be absolutely catastrophic. We're talking about supply meeting barely half the demand. That creates these huge deserts of care exactly where people need it most.
And right on the heels of seeing that workforce shortage, you see this. It's wild. While the costs for hospitals and everything else in healthcare have just skyrocketed, physician pay has actually gone down by over a quarter when you adjust for inflation. I mean, how can we possibly expect to attract talented people to a field when the economic pressure is that intense?
So what's driving this? Well, a huge part of the problem is a payment model called the Global Obstetrics Code. And get this, it dates all the way back to the 1930s. Basically, it's what's called a bundled payment. It gives a single, flat fee for an entire pregnancy, assuming you'll have about 13 visits. Here's the kicker. It doesn't matter if you're a totally low-risk patient or someone with multiple, complex health conditions, the payment is the same. This one-size-fits-all approach makes it almost impossible to figure out what's actually working and what's not.
And this is where the problem really snowballs. OB services rely heavily on Medicaid. In fact, it pays for 43% of all births in the whole country. As you can see from the chart, it's the biggest payer by a mile. The trouble is, Medicaid often pays back at rates that are way below what the care actually costs. This puts a massive financial strain on practices, especially the ones serving our most vulnerable communities.
But okay, it's not all doom and gloom. Not at all. Out of this crisis, a really powerful new vision is starting to take shape, and it begins with completely rethinking what prenatal care should even look like in the first place.
The American College of Obstetricians and Gynecologists, ACOG for short, has put out this game-changing new guidance that just blows that old model out of the water. As you can see here, it's all about moving away from a rigid, fixed schedule to creating personalized care plans. This new way of thinking empowers the whole care team. We're talking midwives and APPs too, to screen for social factors, bring in tools like telehealth, and maybe most importantly, focus on shared decision-making, which makes the patient a true partner in their own healthcare journey.
And this graphic just illustrates the new approach perfectly. Instead of everyone getting the same fixed schedule, the care is tailored to you. So a low-risk patient might have fewer in-person visits, which frees up precious time for higher-risk patients who really need that extra support. It's all about being smarter and way more equitable with our resources. Now, a new clinical model is fantastic, right? But it can't succeed if it's not supported by a new payment model. So let's pivot and see how all this builds toward a totally new definition of value in health. So this brings us to this really crucial idea: value-based care. The concept, which was really championed by Michael Porter at Harvard, is actually simple but totally revolutionary. Value isn't about how many services you provide, it's about the health outcomes you achieve for the patient divided by the cost. The only question that matters is,
Are we actually making people healthier?
And Porter's point here is just so fundamental. If you don't measure the results, how can you possibly improve them? For way too long, our healthcare system has been obsessed with measuring the inputs. How many visits, how many procedures, instead of the outcomes that actually matter to patients and their families.
And this takes us right back to that global fee from the 1930s. Because it bundles everything together, it basically hides all the data. It's a black box. To move to a system based on value, we have to unbundle those services. It's only by seeing what care is actually being delivered, which screenings, which support services, that we can start to understand what's actually making a difference.
Okay, so if we need to measure outcomes to create more value, how in the world do we actually do that? This is the final and maybe the most practical piece of this whole puzzle. And here's the key question, right? Just think about it for a second. You can't manage a C-section rate after all the C-sections have already been performed. That's a result. It's in the past. So how do you possibly influence what happens in the future?
What's so cool about this slide is the distinction it makes, which comes from this framework called the 4 disciplines of execution. It splits measures into 2 types. On the left, you have lag measures. These are the results, the goal you're trying to hit, like a lower C-section rate. But you can't directly affect them after the fact. Now on the right, you have lead measures. These are the high-impact efforts you can totally control that are predictive of that outcome. For example, you can't directly manage the C-section rate, but you can directly manage the percentage of at-risk patients who get screened and enrolled in a support program.
This right here is the big aha moment. You can't manage the lag measure, but you can absolutely manage the lead measure. When you focus your team on executing those specific predictive actions, you move from just hoping for a good outcome to actively engineering it. It's a huge shift from being passive to being proactive about quality.
So this whole journey leaves us with a really powerful question to think about. The crisis in maternal care has forced us to radically rethink everything, from how we practice medicine to how we pay for it. And if we can learn to measure and reward the efforts that truly create better outcomes, we're not just fixing one part of the system. We might just be building a blueprint for transforming the rest of healthcare too.